Um, if you are sitting on the toilet right now, holding your breath and trying to, force a bowel movement, you might actually be doing irreversible damage to your reproductive anatomy.
Yeah, it sounds completely terrifying, I know, but 50% of women who have given birth will experience pelvic organ prolapse. And the way we push, like, our daily bathroom habits,
Yeah.
it's acting as a massive daily accelerant to a structural collapse that nobody really wants to talk about.
Right, which is why we have to talk about it. Welcome to our deep dive. We are tearing through clinical guidelines, physiotherapy manuals, and medical trust sources to answer a very specific, maybe uncomfortable question for you today. Can constipation-related straining actually worsen vaginal looseness?
Taking this out of the shadows is so critical. We tend to compartmentalize the body, right? Digesting food over here, reproductive health over there.
Yeah, like they're in two totally different rooms.
Exactly. But the physiological reality is entirely different. These systems are stacked right on top of each other. They share a single, very vulnerable support structure.
Right.
So by the time we finish this deep dive, you will see exactly how generating pressure in your abdomen translates directly into stretching, weakening, and, well, physically altering your vaginal walls.
To visualize this, I think it helps to picture the bottom of your pelvis. It is not a solid bone bowl. It's actually a hammock.
Yes, that's a great way to describe it.
The clinical sources describe the pelvic floor as this sling of muscles, ligaments, and connective tissues stretching from the pubic bone in the front, like all the way to the tailbone in the back.
And that muscular hammock is the foundational floor for the bladder, the uterus, the vagina, and the bowel, all of them. They are all resting really heavily on that single flexible net.
Just bearing all that weight.
Right. It is constantly working against gravity. Whenever you laugh or sneeze, jump, or even just bend over, that hammock has to absorb the downward shock of all your internal organs.
Let's unpack this with an analogy. It is like carrying 4 heavy watermelons in a single really thin grocery bag.
Mhm.
If the bottom of that bag gets weak, everything inside is going to shift, sag, and eventually just fall out.
That is a highly accurate, if slightly terrifying image. And the sources detail several ways that bag gets compromised before we even get to bathroom habits. Age and hormones dictate a massive portion of that structural integrity.
Because of collagen, right?
Exactly. Vaginal tissue relies heavily on collagen. It acts as this microscopic scaffolding to keep tissues firm and elastic. But, as we age, natural collagen production plummets.
It just drops off.
Yeah, and you combine that with menopause, where estrogen levels drop significantly. The vagina, the vulva, and the urinary tract are just packed with hormone receptor cells.
So what happens when they don't get that estrogen?
When you deprive those cells of estrogen, the lining of those tissues physically thins out. It completely loses its elasticity.
So the hammock essentially becomes threadbare.
Yes, threadbare.
And then, you factor in pregnancy, the sheer physical weight of carrying a growing baby for 9 months, plus the hormonal cascade that intentionally relaxes your ligaments to let the baby out. It pushes that tissue to its absolute physical limit.
It really does. And the immediate aftermath of that stretching is often vaginal laxity. So that's a physical looseness, a loss of tone, and a reduction in sensitivity.
Which a lot of people experience.
Very common. But laxity is frequently just the precursor to pelvic organ prolapse, or POP. The hammock fails to hold the organs up, and they literally physically bulge down into the vaginal canal.
And the stats on this are wild.
Huh.
The research notes 1 in 3 U.S. women will face a pelvic floor disorder. Millions of people are just walking around with this invisible structural collapse.
It's staggering.
So we have this pre-existing vulnerability, right? The hammock is already under duress from gravity, age, childbirth. Then we introduce the pressure cooker, we sit on the toilet, we are constipated, and we hold our breath and just bear down with all our might.
And when you do that, you are basically turning your torso into a physiological piston. The medical term is intra-abdominal pressure.
Okay, a piston. Walk me through that.
Well, when you close your vocal cords, hold your breath, and violently contract your diaphragm and abdominal muscles, you create a sealed high-pressure cylinder.
Oh, I see.
The pressure has to escape somewhere, right? And the path of least resistance is straight down onto the pelvic floor.
So the force is looking for an exit, and it just slams into that grocery bag, holding everything together. But the impact isn't just on the bowel. The intense pressure is driving the bowel directly into the vaginal wall.
Yeah, if you look at the anatomy of the rectum, which stores the stool, and the posterior wall of the vagina, they share a boundary.
like a shared wall in an apartment building.
Exactly. And that dividing wall is incredibly thin. So
Hmm.
chronic, intense downward pressure overstretches the connective tissues tasked with holding that wall firm.
And the wall just buckles. It gives out under the constant pounding of that abdominal piston.
It does. And the resulting structural failure is called a rectocell.
Rectus.
Right, which is a posterior vaginal wall prolapse.
Mhm.
Because of the strain, the weakened rectum literally balloons outward under the pressure, sagging and pushing forward directly into the back wall of the vagina.
It's a herniation,
Yeah.
essentially. The rectum invades the vaginal space.
Yeah.
For you, the listener, trying to picture this, it means you have a soft bulge of foreign tissue taking up physical room inside the vagina.
Exactly.
And that completely explains the vaginal looseness. The muscular tension of the vaginal canal is destroyed because another organ is encroaching on its territory.
The daily symptoms are really debilitating too. Beyond the sensation of looseness, patients experience this profound, heavy, dragging feeling in the pelvis.
Like a weight.
Yeah, a persistent ache that steadily worsens towards the end of the day just because gravity has been pulling on that damaged tissue for hours. Women also report decreased physical sensation and active pain during intimacy.
And the cruelest irony here is that creating this bulge makes the original problem, the actual constipation, infinitely worse. The stool comes down the pipe, but instead of going out, it gets sidelined into that little sagging pocket of the rectocell.
Right, the stool becomes trapped in the bulge, so the patient feels they haven't finished emptying their bowel, and what do? They strain even harder,
Oh, no.
which increases the intra-abdominal pressure, which pushes the rectocell further into the vagina, which traps more stool. It is just a relentless, degenerative feedback loop.
We are forcing the body into a localized structural collapse. I mean, if straining destroys the dividing wall, the mechanics of how we are trying to push waste out must be fundamentally flawed. We are somehow working against our own hardware.
We really are. The clinical literature identifies this physiological flaw as dysynergia, or a paradoxical contraction.
Paradoxical contraction.
Yeah. In a functional bowel movement, the abdominal muscles should create a gentle, coordinated push, but the pelvic floor and anal sphincter must completely relax to open the exit.
Here is where it gets really interesting, actually. It is like trying to drive a car forward while violently yanking up the emergency brake. You are revving the engine, generating all that abdominal pressure, but the exit doors are welded shut. So the force just blows out the sidewall instead.
That's a perfect way to put it. Constipation breeds anxiety, and anxiety causes involuntary muscle tension. People subconsciously panic and tighten the exact pelvic muscles they need to release.
So how do we fix it?
Physiotherapy protocols focus heavily on relearning the biomechanics of evacuation to dismantle this paradox. There is a science-backed technique, playfully termed moo to poo, or brace and bulge, designed to bypass that instinctual tightening.
I want to test this out. Reading about a physical technique is one thing, but translating it to the body is another. Walk me through the mechanics of disengaging that emergency brake.
Okay, so we begin with the foundational posture. You must sit fully on the toilet. Hovering over the seat is disastrous because it forces your pelvic floor muscles to constantly fire to stabilize your body weight.
Makes sense.
You place your feet on a small footstool to elevate your knees higher than your hips. Lean slightly forward with a straight spine and rest your forearms on your thighs.
Wait, the knee elevation has to be doing something mechanical? I imagine there's a specific anatomical reason beyond just sitting in a squat.
Oh, absolutely. It directly manipulates the puborectalis muscle.
The puborectalis.
Right, this muscle wraps around your rectum like a sling. In a normal standing or 90-degree seated posture, it pulls the rectum forward, creating a sharp kink in the tube.
Like a kink in a garden hose.
Precisely. This kink is a brilliant evolutionary continence mechanism. It ensures stool doesn't fall out while we walk or run. Raising your knees into a squat angle introduces slack to that sling, straightening the rectal tube for a clear, unobstructed exit.
Okay, let's assume I am sitting, knees elevated, leaning forward. The hose is unkinked. Now comes the vocalization part.
Yes, we split the technique into two distinct phases. Phase 1 is the actrogamy. You take a deep diaphragmatic breath into the belly, expanding it outward. Simultaneously, you gently engage your transverse abdominis, that's the deep core muscle wrapping around your waist, and hum a sustained sound. Let me try that. Deep breath. Okay, it feels like I'm tightening my upper abs, but my lower belly is still soft. Am I generating the pressure safely?
Well, if your chest is rising, the mechanics are off. The breath must go low to push the diaphragm down, creating a gentle, localized pressure cylinder rather than a violent whole-body strain.
Mm,
The mule stabilizes the core.
got it.
Phase 2 is the release, the ooh. You consciously relax the pelvic floor, bulge the lower abdomen forward without tensing the muscles, and make a low-pitched ooh sound.
Inhales. Mm-mm. And then bulging out. Ooh, wow, I can actually feel my jaw and throat vibrating with ooh. Does the sound actually do something physical, or is it just a psychological distraction?
It is deeply neurological. Physiotherapists use electromyography, placing superficial sensors on the perineum to measure electrical impulses in the muscles.
Okay. These studies prove that low-pitched vocalizations and relaxed jaw muscles trigger a reflex arc that objectively drops the electrical activity in the pelvic floor. The sound literally forces the sphincter to open.
The vocal cords and the pelvic floor are hardwired together. You drop the pitch, and the trapdoor automatically opens. That is a massive paradigm shift. Instead of a violent push, it is a coordinated acoustic release.
It changes everything. Posture and vocalization prevent you from treating your organs like a punching bag. Conservative management is the mandatory starting point to stop further tearing.
Which means lifestyle stuff, right?
Right. Hydration and a high-fiber diet are non-negotiable, as hard stool requires exponentially more pressure to move. Maintaining a healthy body mass index removes constant passive weight resting on the hammock. You must also avoid lifting anything over 10 kilograms, which creates instant intra-abdominal pressure spikes.
The sources also flagged chronic coughing, which I found fascinating. If you have asthma or a smoker's cough, every single cough is a violent downward hammer blow to the vagina. Fixing a respiratory cough is literally a pelvic floor intervention.
It is. The respiratory system and the pelvic floor are intimately linked. But alongside reducing pressure, the goal is strengthening whatever muscle fibers remain intact. This involves pelvic floor muscle training, which is universally known as Kegels.
I know the classic Kegel instruction.
Mm-hmm.
The advice is always, to pretend you are stopping the flow of urine and holding in gas at the exact same time. Squeeze the front and back ring simultaneously without tensing the thighs or holding your breath.
The muscular technique is crucial, yes, but the context of when you do it is even more critical. The clinical guidelines issue a stark warning here.
Oh,
You must never practice Kegels by actually stopping your urine midstream while sitting on the toilet.
wait, really? Because I feel like that's how everyone checks if they're doing it right. I imagine that severely confuses the nervous system. The bladder is actively trying to empty, and you are slamming the exit door shut halfway through.
Exactly. It profoundly disrupts the complex neurological reflex arc between the detrusor muscle of the bladder and the sphincter. Doing it repeatedly leads to voiding dysfunction.
What happens then?
The bladder basically forgets how to fully empty, resulting in stagnant urine and severe bacterial infections. Kegels are an exercise for the living room, never the bathroom.
That is an excellent distinction. Let's look at the immediate crisis on the toilet, though. The stool is trapped in the rectocell pocket, and the breathing techniques aren't working because the structural wall is completely blown out. The sources detail a physical workaround called splinting.
Splinting is a manual intervention. When pushing only inflates the rectocell bulge, the patient must physically reinforce the weakened wall with their own hands.
Wow, manual intervention.
Yes. A woman places her fingers externally on the perineum, the space between the vagina and the anus, and applies firm upward and backward pressure. Alternatively, she inserts a finger directly into the vagina to press backward against the bulging rectum.
You are acting as a human splint. You manually push the herniated bowel back into its proper anatomical vertical alignment so the waist has a straight shoot down. It is an intense reality check on how purely mechanical this issue is.
It really highlights the mechanical failure. But when conservative measures and splinting fail to provide an acceptable quality of life, medicine offers advanced structural support. Vaginal pessaries are a primary non-surgical option.
What exactly are those?
These are flexible silicone devices, custom-fitted and inserted high into the vaginal canal.
So they act as a prosthetic hammock. They sit inside and physically prop up the collapsing organs, restoring tension to the vaginal walls from the inside out.
Exactly. We also look to localized hormone therapy. Prescribing topical estrogen creams for menopausal women dramatically improves the blood flow, thickness, and elasticity of the vaginal lining, giving the underlying structures far better cellular support.
I want to unpack the energy treatments mentioned in the sources too, because they sound a bit like science fiction. Radio frequency treatments, lasers like the Mona Lisa Touch and the Emcella chair.
They do sound sci-fi. Lasers and radiofrequency devices operate on the principle of controlled thermal injury.
Controlled injury.
Yes, by safely heating the vaginal tissue, they trigger the body's natural healing cascade, forcing fibroblasts to rush to the area and lay down dense, fresh collagen scaffolding to tighten the walls.
And the chair?
The Emcella chair takes a completely different approach. It utilizes high-intensity focused electromagnetic energy. The patient sits fully clothed on the device, and the magnetic fields bypass the brain, directly triggering the pelvic floor motor neurons to execute thousands of supramaximal contractions in just minutes.
So it forces the muscles to do tens of thousands of perfect, superhuman Kegels without the patient lifting a finger.
It's wild.
But, I mean, if the wall is entirely ruptured, lasers and magnets aren't going to bridge the physical gap. At what point does a surgeon have to cut in?
Surgery is strictly reserved for severe, debilitating prolapse. A posterior repair involves a surgeon dissecting the vaginal wall, pulling the overstretched underlying fascia and muscles back together, and suturing them tight to manually rebuild the barrier between the rectum and vagina.
I noticed a massive red flag in the clinical guidelines regarding surgical materials, though, specifically transvaginal mesh implants. I've seen the lawsuit commercials on TV. If the natural tissue is thin, I imagine sewing a rigid synthetic plastic net into a dynamic moving area like the vagina acts almost like a cheese wire over time. Is that the danger the sources are warning about?
The cheese wire analogy is tragically accurate for many patients, unfortunately. The synthetic mesh was originally intended to provide permanent structural reinforcement. The complication rates, however, proved catastrophic.
It's awful.
The mesh frequently eroded directly through the delicate vaginal tissues, causing chronic, debilitating pain, severe infections, and profound damage to adjacent organs.
So what's the status on it now?
Consequently, health authorities globally, such as the Therapeutic Goods Administration in Australia, have heavily restricted or outright banned transvaginal mesh for prolapse repair. Any surgical consultation must involve rigorous questioning about the exact techniques and materials being proposed.
Bringing this full circle, our deep dive set out to answer whether constipation-related straining actually worsens vaginal looseness. And the clinical evidence is absolute. By treating the toilet like a pressure chamber, we are physically dismantling our internal architecture.
You really are.
Intra-abdominal pressure forces the rectum to blow out the vaginal wall, destroying the muscular tension and dragging the surrounding organs down with it. Vaginal laxity isn't just an inevitable side effect of getting older for many. It is an active mechanical injury repeated day after day.
And understanding that mechanical injury allows us to halt it. The power lies in recognizing that our physiological systems do not exist in isolation. The way we breathe, the angle of our hips, the pitch of our voice, they all orchestrate the survival or the failure of the pelvic floor.
Here's a final thought for you to mull over. Looking at the pure architectural physics we have explored today, the human pelvic floor is entirely unique in the mammalian world. It is the only load-bearing skeletal muscle group in the entire body that functions horizontally against gravity, while having multiple holes passing directly through it.
Right.
By design, it is architecturally compromised from the moment we stand upright. Every time you hold your breath and bear down, you are launching a directed attack on the absolute weakest structural point in human anatomy. The next time you step into the bathroom, remember that you are navigating an anatomical tightrope. Grab a footstool, take a deep belly breath, and give your internal hammock the respect it deserves.